Hello, everybody. This is our 21st.
Hello.
Welcome. This is our 21st intergenerational meeting. I'm going to leave the moderating to Ramin Aprao. Today, it's a very important day for us. For the first time, we are having a student presenter. Please, Ramin, may we listen to you?
Good day to everyone. And just to clarify, I'm not the student presenter. I'm just going to help to facilitate the events for today. So what we're going to have today is a very interesting topic that I think does not get addressed enough. And we are looking to try to change that. And because of that, our colleague, Farhad, he has prepared a presentation for us today on the topic of gender dysphoria. So without further ado, let's hear what Farhad has to say.
Yeah, hello to everyone. I'm glad to see you here. I'm just going to share my screen and then start. Yeah, if everything okay, I'm going to start. All right. Yeah, just a little bit info about me. I'm Farhad. Actually, I'm from Azerbaijan. I lived in Baku until finishing my high school. And then I came to Turkey to Bursa University to study in medicine. And I finished my 5th year and I will start my internship here in August. And it will be my last year. And I have great interest in psychiatry and I want to do my residency in psychiatry actually. And I have interest in topics related to gender, addiction and depression. And actually that's why I chose this topic. And one of the main points that I choose this topic because when I talk with my colleagues in university, I see that a lot of people, even just students, medical students have a lot of misconceptions related to that topic. Like they don't know the exact meaning of the terms related to gender. And it's like, actually, maybe it's understandable because in Turkey in such kind of Western societies, it's taboo to talk about gender-related topics. And that's why actually it leads to a lot of misconception and to a lot of discrimination and stigma. And that's why I want to actually clarify some terms to who are listening. Yeah. First of all, there are some concepts that we need to understand for non-gender for gender identity and biological sex. And gender identity actually refers to an individual's sense of their own gender. And it's actually subjective experience of one person. And it starts from very early age, like 3, 4, 5. And it's actually defined like feeling on gender as a part of one identity. And actually, it's too crucial for a person perception of gender. And biological sex, it's also called assigned sex. This refers to a label given at birth based on genitalia and other factors like hormone and chromosome. And it's basically actually like when doctor gave a birth to a child and see a newborn sexual characteristic and says that just she's female or he's male and like that. And gender dysphoria comes when there's a mismatch between biological sex and gender identity. And actually, these individuals are defined like transgender in ICD-10 diagnostic system. But not all transgender people actually have gender dysphoria. Gender dysphoria is when this match causing severe distress, dysfunction to a person for at least 6 months. And actually, this is 6 diagnostic category, and at least 2 of them have to be seen in such a patient. And actually, they are general symptoms. That's why most of them are seen in a person who has a gender dysphoria. It's like strong desire to be opposite gender or to be treated as opposite gender or have a sexual characteristics of opposite gender and so on. And actually, I want to say that that's the first like leading stressor for such kind of patients, because it's like when I read case reports, I see that just most of patients use sentences like we feel like we are living in a cage and like in a body that we don't belong, and it actually leads a very high stress level for that people. And actually, it's like biological for them. And I want to talk about epidemiology for a little, just we understand that how common it's seen. And its prevalence actually range from 0.6 and even up to 3 in some studies. And it varies a lot just depending on the study type and the population or the age that's that study question, and even how the question asked. And actually, it's to gather such a data, because it's like, first of all, in Western countries, it's again like people are reluctant to talk about that, or just they don't want to come out or tell their symptoms. And even if they are reluctant, it's like it's hard to just a lot of people actually don't know the meaning of such a terms. Like when you ask that, are you define yourself as a transgender, people ask like, what's the meaning of actual transgender? And these are like difficulties. And actually, the first time that gender dysphoria is seen is in DSM-3 in 1980. And in DSM-3, they're written that actually this disease is seen apparently rare, but they change it after that it's seen apparently uncommon in 1987. And there's one main point that the frequency is increasing across the world. And there are actually a lot of factors related to that, like raise the public awareness and like increasing supporting groups and internet as a source of information and increased awareness between healthcare professionals. And actually all of them are just like causing decreased discrimination towards that patients. And it's also leads that patient now can came to hospital and ask for medication or for help more easily. And actually it's good news. And etiology actually is still largely undefined. Just we know that in intrauterine period, all like gender of brain, gonadal sex, or like sexual orientation are largely determined, and there's no actual data available that like environmental factors can affect the sex determination process. Though some articles that I found that prenatal androgen exposure can affect the fetus brain, like if mother has a tumor while she's pregnant, and if that tumor secreting androgen, then it can like affect the fetus brain and like sexual fetus brain parts, which is responsible for gender determination process. And one comorbidity is autism spectrum disorder. Its prevalence is higher compared to normal population. And yeah, after that, actually, I'm going to talk the social stressors for such kind of people. As I said, there's the physical one, like people is not satisfied with own body. And there's other stresses actually related to society. And stigma, just let me check. There's a Dr. Ling and Fallon in 2001 who developed a widely used conceptualization of stigma, and it has some components actually. Firstly, society distinguish and label human differences, and just dominant cultural beliefs links this labeled person to undesirable characteristics. It's lead to actual negative stereotypes about this individuals. And actually, at the end, it leads to a separation of us from them. And this labeled person experience status loss and discriminations that lead to unequal outcomes. Actually, in all aspects of social life, like healthcare or workplace, or just in general in society. And actually, it's outcomes of stigma for just only a person. And after that, Dr. Mayer in 2003 put forward the theory of minority stress. And it's it's excess stress that individuals from stigmatized social categories as a result of their social, often a minority position. There's actually a lot of minority group in a society. It's like immigrants or even foreign students who are studying in abroad, and LGBTQ plus individuals and transgender. And actually, these people doesn't have any pathology in any way, but because of that, their number is less, and they're in a minority group. They have an excess stress from the other individuals, and researchers identify this stressor as a unique, chronic, and socially based. And actually, we can divide minority stress in two groups, external and internal one. And as I said, social stigma, rejection, discrimination, objectification is external stressors. And actually, sometimes we can underestimate the effect of social stigma, but actually, research shows that social stigma actually has a similar effect, like physical pain to a person. And internal one is like internalized stigma, and it's actually internalized stigma. It's like negative evaluation of a person, thinks that if I came out to a society or family, they will reject me, and even without saying anything to their family, they like every time thinking about that and feel like rejection. And it's actually again similar to the social rejection, even if you are not facing with it. And self-concealment, it's again just like hiding, not coming out, and it's causing a severe distress to these people. And actually, all of this stress are like chronic to that people. And in one paper, even I see its title is like Gender Dysphoria Chronic Stress Model. And actually, acute stress is helpful to our, like it's actually a physical response to events in our daily life, but its main point is to increase our survival in the life, because it increases cortisol, it depresses growth hormone just to increase our energy. But when it turns to chronic stress model, it's all affect to our central and peripheral nerve system and to our brain parts related to like wake sleep cycle, fear, anxiety. And that's why these people has a higher prevalence for mental related disorder. Like at least sort of these people have a mental disorder like anxiety, eating disorder, depression, self-harming, sleep disturbance. And actually schools and university are the main part of it, because when you are child or adult, actually your brain in a maturation process, and it's like more open to harm from the stress, and they actually make irreversible change for those individuals. And like in school and in university, people face with bullying, harassment, and feeling of being unsafe much more. And I found the research, actually there are so little research in Turkey related to that topic, but that the rate of suicide attempt and lifetime suicidal ideation is much higher than related to normal population. And there's a relationship between family attitude and suicide. If family have a supportive attitude to a patient, then suicide attempts actually just decrease so much. And actually, there's a decreased physical activity levels in these people. And actually, if there's I want to make it interactive and to ask just, do you have any like ideas why it can be seen like in these people, like decreased physical activity levels? Just if you have any ideas, just you can share and just we can talk. Just no one?
Well, just to chip in, Farhan, I'm finding this talk really interesting. I think the evidence about suicide attempts and actual suicides is that it's usually a multiple set of risk factors. So not just one thing. And often it's the last straw event. So you'll have 5 or 6 social stresses, like difficulty with your housing, with your social networks with your partner, problems at work. And often it's a minor thing that just is the very last straw and tips people over. So my expectation, if we wanted a study of this, is that there would be multiple social risk factors.
Yeah, I see. Yeah, what you're saying. Yeah, actually, they're like, they have seen more increased substance use disorder, and actually, it's also leading to like increased suicide attempt and ideation, like alcohol use. That's why
alcohol is a facilitating factor
yeah.
in suicidal activity. So it's easier to do it if you're under the influence of alcohol.
Yeah. Then I'm continuing. Just it's the reasons that physical activity is seen in these people, it's like actually they have very body image shame, and like they don't want to wear just body revealing costumes, and they actually don't want to go in a change room because actually they start to compare themselves to others, and it causes more stress for them, and actually that's why decreased physical activity seen in these people. Clinical management and treatment, actually it's out of today's topic, but I want to say that multidisciplinary approach is necessary for these people, because like clinical psychologists or psychiatrists and pediatric and endocrinologists need to be found in this group, and just like in approach in management and treatment of these people. And psychology support is like essential for not only like patient, but also for a family of a patient, because actually it's like if patient is going to like gender affirmation surgery, and it's like big transition in the life of patient and also family, and you need to actually cope with the stressors in their life. And there's the suppression of puberty, and actually it's like one of the main main treatment in these people, and it has 2 main points. First of all, just this actual secondary sex characteristic cause severe stress to that people. That's why suppression of puberty also will seize the development of sexual characteristic, and it will decrease the stress level for that people, and it will give a time for that people to for that patient to think about like to like manage their past in that process. And of course, and also if they're going to do surgery, it will make it easier because their, again, sexual characteristics will not develop fully. And after that, gender affirming hormone, actually it's a irreversible part of the treatment, this hormone and surgery. Because after that, just actually the changes are start for a patient body. And gender affirming hormone is like to give hormone for people to develop sexual characteristic for desired gender. And you can start it from after 16 age. And gender affirmation surgery is also can be done after 18 age. And both of them, as I said, need to be like decided very critically with family and with patient. And there's a fertility. Actually, if a patient is like in a post puberty phase and want to be a fertile, the sperm or oocyte can be banked, and and these people can have a future fertility. But if a patient is like pre-pubertal, it's again need to be evaluated with patients that it's if the fertility is essential for that people or not, and so on. And what can we do? Actually, I have some, again, suggestion, but I want to hear something again from you, just like, again, brainstorming here, that what can we do, like, related to decreasing their stress level as a student, as a professor, or as a, like, person in a society? Just don't be silent, just say something. It's
Well, or if I can chip in again, then
Yeah.
I'll express my concerns, I suppose, that I think, well, certainly in the UK, where we've had the scandal of a clinic at the Tavistock, I think a number of us have become very concerned that people are being led into premature decisions about their sexuality and about their gender. And that, well, just to put it in basic terms, that children, adolescents, well, when you go through adolescence, it's normal to have confusion about your gender identity and about your sexuality. And that by and large, by the time you emerge from adolescence, it's all settled down perfectly, and you know exactly who you are and where you're going. And that to kind of interfere with that process, which is a normal process of kind of self-exploration and identity, is to lead people into premature decisions that they may later regret. And we do have some cases in the UK of people who've had gender changes, you know, surgery and so on, and now bitterly regret it. So one of my suggestions is that we just kind of slow down, I suppose, and take things much more slowly, so that people don't make irrevocable decisions that they would subsequently regret. And also that therapists are more understanding that, for example, if you have a girl who just feels rather a tomboy and doesn't identify with girls who, you know, like lots of lipsticks and etc. She may, if that you can imagine a kind of culture where she may feel, well, gosh, perhaps I'm a boy, perhaps I'm really a boy, and she isn't at all. She's just, you know, on a different part of the spectrum of what it is to be female.
Yeah.
I know I've had conversations with David Skews, who's professor at Great Ormond Street, who said that he's seen quite a lot of girls like that who are actually perfectly normal girls. They're just feminine, which of course they don't have to be part of.
Could I ask you, if you had a son and if he suddenly discovered that he has gender dysphoria, that he is feeling that he would like to be a girl, what would you do? No, I'm not asking you, I'm asking Farhad, because he's been studying this.
Yeah, actually,
after all that you have studied now and you have read and prepared this very elegant and nice presentation, concretely, what do you do if your child suddenly tells you, I don't want to be a boy, I want to be a girl, or vice versa?
Yeah, probably, first of all, I will try to talk with him, like the reasons behind of that, like just from when he feel like that, or how it happened, or just like it's something happened, like just trying to find out symptoms or just the thoughts behind that decision, and maybe then just take him to psychiatrist, because actually when I talk with my professor in Bursa, she also says that just there's a patient that came and she has a severe gender dysphoria, but when just they actually do some therapy with her and they see that actually she has some trauma with her father, and like actually there's a harassment story, and after actually being apart from her father, just his for example, gender dysphoria just like decrease like critically. That's why I mean, like, after talking and taking him to psychiatrist, I will approach like that.
In a way, the wanting to change one's sex is considered a disease. Is this really a disease, in your opinion? Because
You may
about treatment and medical interventions is a treatment. So by definition, if it's in the DSM, it's a disease. But would you consider it a disease, or is it something else?
like I think being transgender is not disease, but gender dysphoria just like causing this severe distress. It's like actually, yeah, not disease, but it's disorder.
But I mean, the disorder, excuse me, but the disorder comes from the fact that other people don't want to allow that person to change his gender. That's where the unpleasantness comes from, because they say we would like to be different, we like to be the other gender, and everybody else says, no, you can't do this. And so because of that, they experience a variety of problems. Because if somebody said, all right, you want to be another, we'll change it, there's no problem. They say, go over there, it will do the change of your gender. It would, so by the fact that we call it a disorder, it means that we feel that it's a disease rather than an expression of a decision about one's, where one feels more comfortable in which gender.
I would chip in on that. I would actually add on
I'm
to what
just
Novan actually mentioned.
It is some very important questions about where does the limit of a disease and social deviance stop, and where does the normal decision making begin. It's not always easy to see. But I think Dr. Afzal has an answer to that question.
No. No, thank you very much, sir. No, I don't have the answer. But let me first congratulate our medical student for talking and presenting such a complex issue in a very simple way that really makes us understand the situation, the gravity, and the complexity. My personal feeling is that this is one of the areas within mental health that is very gray. And you rightly says that if we call it a disorder, that means it justifies a treatment, a medical treatment, a social treatment, a psychological treatment. But I think we have to really look at this particular issue from a perspective of culture, that what is normal and what is abnormal in a culture. And this is an area which has gained a lot of attention, especially about this gender identity in the West. But what happens in many other countries, especially low and middle income countries, where at some places it is considered as a taboo, at some places it is considered as a deviance, and at some places it's not even recognized as something that needs to be helped. So I think it's very difficult to answer your question, but at the same time, this is an issue that probably needs to be included in our curriculum, especially looking at one aspect that if somebody is presenting with this orientation, what is the underlying cause? Is it underlying mental health problem that is pushing that person to go for that? Or is it there is no underlying mental health problem? I think this is the most important thing, because just declaring someone abnormal on the feelings may be very dangerous, but at the same time, we may be missing what's really undergoing. I mean, I don't want to jump into that, but it could be a delusional idea. It could be an overvalued idea. So probably a proper assessment, as has been said by Fahad, is very important to look at this, that why this particular issue is emerging now. And then based on that, proper assessment, evaluation will be able to give us some idea that is it related to a mental health problem? Is it just a sort of a preference, or is it something different?
Yeah, well, there are probably two types of dysphoria. One, which is based on the unhappiness about one's own gender, which is the consequence of a mental disorder, and the other one, which is the consequence of a decision. I don't feel comfortable in this particular gender in which I am. And I think those two would have to be distinguished, probably. If a person with schizophrenia suddenly wants to become a different gender, you would want to deal with schizophrenia so as to bring him back into a situation in which he can make rational decisions. But the problem is, of course, that the parents who will see their child wanting to change gender are seeing also that that child will have endless problems when growing up by all the things that you mentioned, the stigma and the disregard and unhappiness and everything else that goes with being different, with being considered as a creep, being considered as a curious, abnormal person. And the treatment that people have been given to people who are, even people who just cross-dress, has been terrible in many countries. I mean, they've been beaten up and they've been in many ways punished for what they are. So I can understand the anxiety of parents who say, wait a minute now, what is the fate of my child? How will he or she live if he now changes gender and has to join a group that is not so very, very welcome? So I think that additional problem emerges. That's dysphoria in the parents or in people who are carers. They don't know what to do about this. They would not like to expose their child to this bad role that this child might have in the future. So there are three problems. There's the problem of the person who is wanting to change gender. There's a problem of carers or people who are around him who don't want to allow this. And there is the problem of us as doctors. Are we, in fact, authorized to do some things of this type? We are not treating a disease. We are doing something. We are changing gender. I do not know whether this is, Rachel will maybe tell me whether the Ministry of Health of England in its time has been accepting that such action would be seen as part of the normal medical treatment or normal medical task, because that's a different proposition from all of it altogether. So I think that it's an issue where the health, the mental health part is extremely complicated.
But sir, going forward, what do you think that from the professional's perspective, what should be the guidelines or the directions for professionals who have to deal with all these three aspects of complexities which you have just mentioned?
Well, I think that part of the solution is, in fact, in our trying to achieve a better acceptance of the group of people who are different in any way, accepting people who are different by their gender, who are different by their color of skin, by different, raising the tolerance of people to people who are different. And that's something that is a significant task of parents and schools, which they are not doing. Schools, in some countries, they do it, but very rarely. But basically, learning how to be tolerant to people who are different is a task of society and of parents and of everybody else. So that's one thing. Once we have got that in mind, that in fact we should be able to tolerate and accept people who are different in any way, we've done a lot of. Then we can start talking about how best to help people to find the right way for their life. But I think that's one task that is very important. It would be nice if the schools had a continuous element that deals with acceptance of difference, acceptance of people who are different in appearance or different in ideas, or the acceptance. That one is increasing the tolerance of society, which is a much larger problem. Once that is done, there is also the tolerance of not a large society, but the small society, of the family or culture or another group that is present as well, which is another task that we have to undertake. Because under the conditions that we are not in fact allowing this. We are trying to direct that or help that person who has a gender dysphoria to become, to somehow find a way in life. Now, once that is resolved, I think that the problems for us would become much easier to resolve. Basically, doctors are supposed to deal with disease. Now, it's questionable whether wanting to be different is a disease. I don't know. I would say it is not, but you want to sort of help these people to find a way. But the other question is, of course, that many of these people who have want to be of the different sex are becoming or thinking about it when they are 14, 13, 15, 16. And that is a bit too early. So I think that probably one would have to think of keeping everything undercover, more or less, until such time as the person who is before us can decide for himself or herself what they want to do in life and what they want to be. And then we have to act in concordance with what they want, but they being adults and sufficiently in a clear mind to make a decision about what happens to them. And so that's really, for the younger one, we really have to postpone decisions. And that's probably the main thing that laws should foresee. Changing somebody's sex at the age of 13, I think, is not the way to go. I think that we have to wait with this, and meanwhile apply problem solving and other techniques of psychotherapy to reduce the problems that exist in the person and in the family that is there. And then once we reach the age of maturity, where people can make the decision for themselves, we can then think of hormone or any other method of helping the person to be in the gender that he or she wants. So
sir, just for the attention of our medical students, and it's not a commercial plug, because World Psychiatric Association has been facing this issue, because from many societies, from many individuals, we have been getting reports about what is the position of World Psychiatric Association on this particular issue. So I just want to add this, that we have asked a group of experts to prepare a position statement on gender identity and same-sex orientation, attraction, and behaviors. We have got this position statement available on WPA's website, which gives a professional association's attitude, especially about this, what should be the underlying principles when we deal with this particular issue. I would encourage medical students to look at this position statement, which we will be presenting to our General Assembly for discussion and approval in September. But what that position statement emphasizes, that this issue is becoming of so importance that it needs to be included in the curriculum, so that our future mental health professionals are well equipped in terms of dealing with this issue, which may be present for many, many years, but now these issues are becoming more apparent and more visible in terms of our practices.
Yeah, I think that one of the probably, I've met several parents who are terribly distressed and not know what to do. And I think that the attitude in many countries is nobody knows really what, and the rules, probably the position statement will be a very helpful thing, basically stating that the decision must be made by an adult about his or her life, and that meanwhile we should protect both the family and the individual from bad treatment that they might otherwise receive. Because the stigma begins not at the age of 18, it begins it could begin much earlier, and the life in schools can sometimes be hell for children who have want to be of a different gender. And of course, the whole question of tolerance in society at large is present as well, because questions that we are dealing with here are questions that are also similar in racial discrimination and in various other forms of discrimination that we should probably resolve in some way or another. And I think that the important point, which I would think is really that the focus of our attention and focus of our work in many ways should be to convince people that it's the age between 2, 3, 4, and 5 where people create attitudes and create concepts. The stigma of mental illness, for example, is more or less completed and embedded into one's mind at the age of 5 or 6. because it's the concepts which are created. I always give the example of concepts creation at that age, the early age. A small child of 2 or 3 or 4, he sees animals which are big, and some are small, and some are running, and some are very fast, etc. And all of these animals are very different from one another. But what is common to them is only that they bark. So anything that barks is a dog. And in the same way as this concept is created to help the child to deal with the complexity of the world that deals around it, is a number of other concepts which are created, including the concept of who is dangerous, including the concept of who is different, including the concept whom we should avoid. And these concepts, once created, are difficult to discharge, difficult to change. And so I think that one of the important parts of the action should be really a significant amount of parent training and school change that would deal with the intolerance and the lack of acceptance of people who are different, which is the solution to many of the problems later on.
Yes, I also wanted to say that, yeah, just when you first say that we actually need to postpone like sex-affirming hormone or surgery, like more lately, but it's like we also need to like change this stigma and discrimination from starting early age, because if patient has these stress factors from starting childhood, then just postponing the surgery will lead his or her much more stress, because just she or he need to live much more with that stress. That's why if you are postponing actually this treatment, we also need to like change this society and just make more tolerance that at least these people have more like, how can I say, better mental health, and they can maybe deal much better with the stress of gender dysphoria, and they can like think more like wisely, or just say can decide appropriately that does they really want to change their gender or just it's other thing.
Well, that's certainly, you are very much right. And I think that what you are saying really in addition means that it's not enough that we deal with a child or the young person who wants to change his gender, but that we have to provide significant help to the family to both help them and guide them and give them support, because they are very often terribly distressed. So it's really a case of everybody being distressed. The young person by not being what he wants to be, and the parents by being unhappy about this child, which suddenly was supposed to be a boy, but in fact wants to be a girl. It's really a good example of an instance where a good doctor will have to deal with the family unit rather than with only the case who is for him or her. And I think that the families very often suffer very badly from this, because their ideals and their hopes and many of their things seem to be going down the drain. And so changing them is something that is a doctor's role. But changing the education at the same time and insisting on parenting training is another story that we have to probably propose to the public health authorities to do. I'd like to know what the other participants think about that problem. They are wonderful to look at, but it would be nice to hear them as well.
If I could change the direction a bit over, while we have always talked about gender dysphoria in most countries being diagnosed too early and it kind of being imposed, there is one more perspective about gender dysphoria. In certain countries, which I'm not going to name, but in certain countries, there is a strong component of religion. And gender dysphoria is a term that has been used by the mental health practitioners, and I think Professor Afzal already mentioned about the positional statement earlier, but there are practitioners who use this particular diagnosis as a catch-all to label patients or to label individuals who do not fit within social norms of sexual identity. Pretty much in a very crude way, if you are not heterosexual, you will have gender dysphoria. This is the most simplistic manner. In your readings, Fahad, have you ever come across anything like that? This would be at the extreme end of what we have been discussed here. This would be an extreme end, but it is a common occurrence. I do know a number of countries who have practitioners who would use gender dysphoria in such manner.
Well, I mean, the recent law of Uganda, which is, provides death penalty for homosexuality, a good example of the power of stigma and intolerance that many countries have. And I think that undoubtedly has to be taken very much into account to not to ruin and allow that people be ruined by it. So I think that that's another thing which we should probably have in mind when we're doing all this. The power of this social intolerance and is enormous for, and it doesn't only touch the person who is in question, but also touches the family and friends and everybody else.
Yeah, actually, it's really different, I guess. When I talk here with my professor in Turkey, she says that we have a patient like in an age like 40 or 35 that came and says that we have gender dysphoria. And actually, she says that it's actually there's a decreasing of age, like patient now come much earlier. But actually, it's like, as Eugene says, there's really differences between societies, I guess.
I was just going to tell you a story of a patient that happened to me in the 1970s when I was a young house surgeon. It was my first job after qualification at Kingston General, which is just on the edge of South London. And one night, somebody came into casualty, bleeding to death, a man in his 50s, because he had constructed a homemade guillotine to chop his penis off. And it was half off when he came into casualty. In the nick of time, really, and I called in the senior registrar who constructed a vagina for him. He completed the amputation, so to speak, and with the remaining skin, constructed a small vagina. But when the consultant came in the next day, it was clear that he would not have done that. Now, this was in the 1970s. And a man who, I wasn't a psychiatrist then, but he was obviously very depressed and distraught about his gender identity, and had had no help or support at all, I don't think. So it's a terrible thing to be driven to. So I guess I tell this story just to show that gender dysphoria happened then as well as now, and that people are driven to extremes if they feel they're not getting the help and support they need.
And of course, the gender dysphoria is not necessarily appearing alone. It's very often comorbid with other problems. So that people may have also a depression, which sits on top of that, or some other condition which has to be dealt with before one enters into this particular area.
In hindsight, he was depressed and a very socially isolated man. He was not psychotic.
And also actually watch the movie, and actually just let me show it for sure. It's like I put two movies, and the scroll one, there's also just actually he's a boy who wants to transgender to a girl, and she also actually cut at the end, cut just her penis because of psychological stress. And actually her family is like supporting her, and she's actually going to hormone change, but just like hormones is not working, and in spite of them, just all the support, just actually she has a lot of pathologic psychology pathway, and at the end, just like actually she has some comorbid, like even with the support.
Yeah, it's a very good point. But I think that establishing that gender dysphoria is not necessarily the only problem, and that there are so many factors around it and other diseases that are present, and societies and culture in which they exist, and that the solution must be strictly personal. They cannot be the same solution for everybody, because not all parents are the same, and not all friends are the same, and not all countries are the same. So it's not being aware of these factors, which probably is what we can teach in medical school and subsequently, but having empathy with people whom you're seeing and thinking what is really what one would do for them is an essential element in addition to professional skill.
Perhaps we may hear from the other students who are in the meeting as well. Let's hear your thoughts, Irem or Zehra, Sena. Maybe I can start. There was something that's been on my mind during this presentation, and that's the idea that if a person's identity may not necessarily be construed as an illness or a disorder, it brings up an interesting point about personality disorders, I think, because in my opinion, personality disorders also, there is a tendency where patients or clients may see themselves as normal, as that's how they identify themselves, that's their personality. They may not necessarily see anything wrong with it, but it affects them in their areas of life and so on. But that's just something that has been at the back of my head, which probably might be interesting for a discussion for another day. I'm not sure what the rest of you think about that.
I don't think quite I understood what you were asking. Are you asking about additional problems that the person has, or whether should deal with those problems before one goes into the gender question, or what was specifically what you wanted to find out?
Oh, I'm sorry if I made it unclear. What I was saying was a totally different scenario. Apart from gender dysphoria on its own, people with personality disorders, where it's a problem with how they identify their personalities and in their areas of cognition, affect, and so on. So if how they see their personality is, they perceive their personality as being normal, that's just how they are, that's normal to them, but it may not be normal to within their social background. So I'm just wondering if that could also be a form, something that we should think about when we consider restructuring disorders or illnesses in the mental health perspective.
Yes, but that brings it back to the definition of what is an illness and what is a disorder and what is an abnormality, which becomes a problem because of the intolerance of other people. You may have an abnormality which is neither a disease nor a disorder, but if it is considered a bad thing by others around you, it becomes suddenly a subject for seeking help and subject sometimes for medical interventions. And here is a good example of that. The question of whether changing sex or not changing sex is good or bad is really secondary to the acceptance of the surroundings which surround that person and the way in which they see it and the fate and the life that one leads because of being different from other people. So it's a more complex issue, and it really puts the question of what is a doctor's role into the first line. What is the role of the doctor? And psychiatrists have a particularly different role from others, because in addition to being concerned with mental disorders, they are very often also asked to think about what is the society's action and in what way that can be corrected. And that really requires also skills and knowledge from sociology and psychology and many other disciplines which are not necessarily with them, so that they are having a more difficulty in advising and giving proper advice concerning that to other authorities, not only to the person who is before them.
And I actually ask from other like Turkish students in Bursa. Actually, I there's no any community related to like LGBT or like for transgender people. Just is there any in your university?
I think yes, in Istanbul University we have some sport program, but I'm not sure.
Well, I think that it's maybe, I think that would be helpful for a discussion between people. Talking about it clarifies one's mind a little bit, and one becomes more aware of pitfalls and difficulties. And maybe one of the solutions could be a group discussion among medical students, even if the doctors are not necessarily not paying sufficient attention. It would be nice if one had it as a normal part of the medical education to deal with this. And maybe Dr. Afzal's position statement will stimulate people to start introducing it into the medical curriculum and also into the various other documents that we have, the documents about ethical behavior in medicine and a variety of other things that WPA has produced.
Professor Koskan, you are not responding to any remarks. I mean, you are the architect of this group. So what are your views? I just want to suggest one thing that like this, which is a very interesting discussion. The students who are attending this, they must complete a reflective document or reflective note after these talks, so that there should be some clear understanding that what they have learned or what they have really found interesting of these discussions.
For me, this discussion itself is the target of our organization. I mean, SEED. Ferhat being the primary speaker is good enough. So I don't want to go into the details of the subject. I want to see it as a general interactive activity.
So are we winding up the discussion or?
Well, the moderator is Rami.
Yeah, I suppose if we do not have many more thoughts, we may conclude the session with maybe some final statements from anyone, if there are any. Maybe Farhad, if you had anything that you wanted to say in your last few slides that you didn't manage to get out.
And I just want to join Dr. Javed by giving compliments to Farhad for preparing this and for thinking about it. And I would like to maybe one suggestion, the slides which you have could perhaps be sent to the people for any comments that they might have. Perhaps they will be a little bit more courageous than they are now by expressing their opinion and thinking about it a little bit more. I certainly am grateful to you for having prepared this, and it was a nice presentation, and it was covered all the important points.
Just thank you so much for your words. Just thank you for participating. Actually, yeah, just you're going to say something, Dr. Rachel.
Well, thank you. I also wanted to say, yes, how good I thought your presentation was and how interesting and important the topic is. It was to add, we've mentioned schools, but I think it is the other really important arena to give a lot of support and thought to, really. And taking the view that one doesn't want to rush into premature decisions, then I think teachers will need a lot of support in kind of being flexible and handling gender variation, if you like, so that there's no stigmatization, no bullying in the playground, so to speak, or by teachers in their attitudes, and so that children don't receive any pressure at all at school to rush into premature decisions. And so really, yeah, it should be part of the whole school approach to mental health promotion, which there seems to be a very good evidence base for now across different cultures and income settings. Yeah, so thank you, Fahad.
Yeah, just thank you for your, actually, it's really different views that I also like. You both just talk about the premature decision, but actually here I state about like just giving, how can I say, much sooner, and it's really actually different, the cultural differences, and I don't know, just I was thinking about that and just what we can do. But actually, it's like I don't know how we can increase the tolerance. It's actually like it's a matter of time, I think. Like when we look to Europe or just United States, we see that these people have more tolerance to such person, but in here it's not a case. And it's like I think there's some time needed for like to educating people or to society that maybe we can overcome and come to the point that maybe Europe has tolerance for that people.
Yeah, one of the major influences is, of course, the faith groups, the religious groups. So it's another area to liaise with, whether it be Christianity or Islam and so on. None of them have a good track record in being tolerant of homosexuality, particularly. And then gender dysphoria probably follows some of that as well. So it's another area to link with, so that people aren't told that this is a sin, or indeed that it, well, as in Uganda, they've just passed a law, I think, that homosexuals are to be executed. So, and a lot of this arises from the attitudes of the faith community. So there's a big area of liaison there as well to be done.
All right, well, I'll have to leave you now. Thank you very much for inviting me, and thank you for the paper, which I hope you'll write it up more and publish it as well. It'll be very educational for many people to read something about it and to read from particularly a topic that is currently becoming so much problem for many people, families, but also for doctors. So thank you very much for inviting me, and I wish you well. Thank you.
Thanks. Maybe time to close, huh? It was so nice to be all together. Hope to meet in 10th of August.
Have a good day.
Thank you, Fahad. Good luck with your final year. Yes.
Thank you.
I'm delighted you're going into psychiatry.
Thank you.
Lovely to see you all. Thank you, Bülent. Thank you, Ramit.